I see that Dr. Mace is logged on now, so I'll turn it over to Dr. Mace.
Great. Thank you so much, Lizeth. And again, welcome everybody to the August edition of our Public Health PBRN virtual meeting. Looks like we're getting a good good group of people together joining us today. So I think in the interest of time, we can go ahead and get started. As we always do, the first segment of our agenda is our Research in Progress segment, and this month brought to you by our colleagues with the Ohio Public Health PBRN, known as RAFI. And we are pleased today to have two members of the research team from this particular project, a quick strike project that Ohio has undertaken, looking at public health cost estimation issues, and particularly in looking at issues surrounding consolidation of local health departments. And so with these two projects, we have, I think, the first set of research issues we'll be hearing from Dr. Patrick Burnett and Matthew Stefanik. Patrick is a colleague, a fellow traveler in the public health services and systems research world. It's well known to many of us. Actually, he's based at Florida Atlantic University as a faculty member there, but works with, now has done work with several of our public health PBRNs on their cost and financing related research projects. And so Patrick has been working with the Ohio network on this set of studies. So Patrick, and then Matt Stefanik, who's also well known to many of us in the public health research and practice worlds, a longtime local health director in Ohio, who has recently transitioned from that job and is able to do a number of other higher level issues around public health research and practice. So we're great to have Matt with us. And then for the second section of this presentation, the presentation on the research on consolidation issues in Ohio, Matt will be joined by his colleague, John Hornsbeek, who's a faculty member at Kent State University, who's been doing some great work on this topic of consolidation in public health in general, and has worked with Matt and other members of the Ohio PBRN RAFI on that project. So thank you, Ohio team, for putting this together and being with us, and I will turn it over to you.
Hi, good morning. Good afternoon. This is Patrick Burnett. Just a quick check to make sure people can hear me.
Yes,
we can hear you just fine.
Okay, good. Very good. Thank you. So quick thanks to Robert Wood Johnson, to RAFI, the Association of Ohio Health Commissioners, without whose help this project couldn't have happened. Also, a special thanks to Matt Stefanik, who will be on the line and share this presentation with us shortly, and Simone Singh, who helped a lot with the analysis and who is probably splitting her duties right now. I see she's on. She's probably splitting her duties right now between this and more important matters, her brand new baby girl. So as soon as I figure out how to make this go forward, there we go. Now, this project started with Ohio's Public Health Futures Report, which kind of detailed their core public health services and their foundational capabilities, a lot like IOM's minimum package. Now, once the core services and the foundational capabilities were defined, Ohio wanted to find out how much it would cost to provide that minimum package. And we started with two basic data sources. You can see here for the expenditures, we had their what they call annual financial report. And what we did here is we kind of split those costs into clinical and core capabilities. And I wanted to apologize quickly if it sounds like I'm working in a construction area. If you're getting a lot of noise, it's because they're doing some remodeling right next door. So this split turned out to be fairly helpful because I've done a lot of cost estimation models before, but the split between the core and clinical turned out to be extremely helpful, helped the precision a lot. They also had staffing information. It wasn't aligned along the same categories, as you can see. And what we did is we split the staffing between the same trick between clinical staff and core or foundational staff. So the first thing we did, and the reason I'm showing you this information is that you can kind of see that you don't need absolutely perfect information or super in-depth information. This is fairly high-level information here and here. I was grateful to have it, but you can see that it wasn't super detailed, and the staffing did not match the expenditures in terms of categorization. So we had to kind of lump them into these two generic, clinical and core foundational, so that we had staffing aligned to both of these. But what happened is we were able to build a fairly precise model, as you'll see. And I know some of you have heard this before, so I'm trying to give the summary version. We used, Ohio did a study, they called it improvement standards, which are virtually identical to FAB's accreditation standards, to measure the degree to which every health department met different categories. One of the things, I'll just give a kind of a little side commentary for the FAB standards. I know that a lot of them are pass-fail, and they don't really distinguish which ones are more important than the others, but for analysis, since we'll be having these in the future, it really would help to know which ones are kind of more important or scores for each one. So we also used to look at service inventory or service mix, we used the NACHO standards. We broke those into these 6 different categories. So what we were going to do is we were going to see if the service mix, not just total proportion of all services performed, but if certain services seem to require heavier services than the others. We also, as part of this project, did a kind of a quick little survey, and we weighted each one of these according to rough expert opinions on resource use. It turned out to be fairly helpful, where we had practitioners just kind of let us know, relatively speaking, how much more resources clinical services used than I think we used population-based services as our baseline. So the last thing we did was demographics. We aligned the health districts to county subdivision borders. It's extremely boring, but if you play with census data for a long time, that turned out to be one of the best things we could have done, because in a lot of public health, you have county agencies that exist for the entire county except for a city within them. Now, if you can get census tract borders, that would be more accurate. But census tract borders tend to be pretty hard to find at the lower level. And we found that these county subdivisions worked fairly well. It was easy enough to identify the health districts using these county subdivision borders. And what it did is it did allow us to perfectly separate the city from the surrounding county in terms of the demographics. That also helped us a lot in terms of the model accuracy. So we put all of this in, there it goes, yeah. So we put all of this in some regressions, and I'll talk through some of these characteristics in a second. Can I zoom in? Yes, I can. So you can see that we were trying to estimate in this model, the dependent variable was number of full-time. The dependent variable is number of full-time equivalent employees. And we did four types of, we did more than that, but I'm showing 4 types of models. One was not weighted by population, the other was population weighted. For the purposes of time, I'll focus on the population weighted one. Now, some of the things that we found particularly significant right here, rural areas were, you can see the positive means that they needed more staff. So the more rural you were, the more staff. And actually that's percentage of people and percentage of population in the area living in what's classified as a rural area. So the more rural, the more staff you had. The higher the percentage non-white, also again, they're all large numbers, and they're all significant, so you can see that you were getting more, you had more staff. Now, one of the tricks in this model here, you can see that we dropped it for a second. The reason we dropped race for a second was sometimes I've seen in other states where race disappears, or the significance of race disappears when you add income and education. So in this case, we still had income and education in the model, but it turned out that you do need race. Race really was a very significant factor in these. Now, the percentage non-English speaking turned out to be a surprise. It was negative, and as you can see, it's pretty strongly negative. Normally, you associate non-English speaking with higher public health needs, yet this is kind of clearly indicating that those areas with higher percentage of non-English speakers had lower staff. That was also true in per capita models, which I'm not going to go into for purposes of time. Now down here, when you look at levels of effort or measures of effort, if you look at the NACHO services, just the overall breadth of all NACHO services, and the percentage of those NACHO services that were aligned with core services, you can see both of them. We used both alternatively, but they were both positive, and the core service one was very positive and strong. We kind of liked that one more since we were trying to predict core services. So in other words, the greater percentage of core services you're fulfilling, the more staff people. This is a staff model. This one is estimating staff again. The more staff you're using. So that's not surprising, but it was nice to see everything working the way you expected, except, as I said, for language, which came as a bit of a surprise. When we put it all together, we had some extremely strong, like 90% adjusted R-squareds for estimating total core staffing right here and total core spending. You can see the diagonal because the estimates are along the bottom and the actuals are on the vertical axis. The fact that the points are so tightly clustered tells us that this is just kind of visual confirmation of the very high R-squared. In other words, this model, the one we have right up here, this model, and you can see the R-squareds down here. There they are, the 0.9. I don't know if you can see my cursor, sorry. 0.9, 0.85. So those are very high. Scrolling down, excuse me. Scrolling down once more, one of the tricks, and one of the other questions we wanted to answer was whether or not there is economies of scale. So what these two graphs do is it has population along the bottom axis, and it has full-time equivalents or spending on the vertical axis. You can see what we found is that both lines are pretty flat. If there were diseconomies of scale, in other words, the more population you had, the messier things got, you would see it trailing up as you went right. Or if there were economies, you would see it flattening as you had more population. Oh, wait, apparently I can draw. That's not going to happen. Okay. It's not going to, but you would see it trailing up this way if there were diseconomies of scale, or you would see it flattening if there were economies of scale. But in both cases, the line was fairly straight. So in terms of the discussion about regionalization, it says that it's hard to prove that there's economies of scale. By the same token, it's also hard to say that there's diseconomies of scale, which is something that I've often heard in discussion too, which is the smaller districts don't want to regionalize because they claim that there's diseconomies of scale, which we couldn't find. All that said, we will be looking at this a little bit more in the future because you can see when we looked at some of the per capita models, at least for staffing, we did find that a negative coefficient right there on the population size. So that would indicate that there's potential flattening in costs or staffing as we go on. Now, all of this led into, and Matt's on deck, this is my last slide, all this led into the creation of two models where we took the regression coefficients here from our findings, and you can see what the R-squareds were down there. And then basically, if you have a health district or even a hypothetical health district, you can enter just these 11 different characteristics, whether or not you're a city or a county, your population, some of your demographics, those core services, percentage of those core services that you fulfill. You enter these, It just does a little math, multiplying it by this, in this case, the population-weighted coefficient. It does the math, and it gives you estimates right down here. And this was the strength of the model. The estimate turned out to be fairly precise. In this case, this health district was fairly close. But what this model also would do, so this one is the model for spending. We also did the same model for staffing. What this model does is, in the privacy of your own office, and you can close the door and you can put in your own numbers, and you can look at what you know your actuals right here, 15.12, and you can see what the average, over here, this would be the average. We're not saying best, we're saying average, what the average health district would use in terms of staffing if they had the same demographics as you and if they were performing the same percentage of core services as you were. So this is a way for health districts to compare themselves to their peers. One of the other things that we did with this that came out incredibly helpful was we could do gap analysis. And at this point, I'll turn it over to Matt.
Thanks, Patrick. Are you controlling the slides? Can you give me control?
You can control them. Either way, on the bottom ribbon bar, there's an arrow that goes up or down. If you want to turn them yourself, you just push the down button.
Okay, I may ask you to advance the slide
That's fine.
to the next slide, please. Thank you. Yeah.
Mm-hmm.
So that's good right there. So we wondered if this cost estimation model could be used to actually do a gap analysis on what Ohio health departments were spending on core services right now and what it would cost if all core services were being provided in all local health departments in Ohio. And the prediction model does allow for that to happen, although it's not feasible nor is it necessary or desirable for all local health departments to provide all core services because some services such as emergency preparedness, sexually transmitted disease control, epidemiology services, and other functions are more efficiently provided through cross-jurisdictional sharing agreements that are quite commonplace in Ohio. In 2011, our SACHO, the Association of Ohio Health Commissioners, reported that more than 2/3 of health departments have such agreements in place for services sharing. So it certainly isn't something that we're recommending, but we were wondering if the model could be used to scale up estimates and determine a statewide gap between actual spending and staffing and some optimal level of services. So I've just lost my connection. Sorry. I think I want to ask Lizette to advance the slide to
Sure. The gap analysis staffing slide is up right now.
Okay, thank you. Happened at an inopportune moment.
It's slide number 11.
Okay.
Well, yeah, this is Patrick. I'll kind of talk him through while he's getting connected again. So what we did is similar to a few slides ago. We took every health district and we whited out the names so you can't tell who's who. But we put in their actual parameters for all their population, their percentage of for the staff doctor availability, but for percentage of core services, we changed each one of them to a 1. In other words, we assumed that each health district was performing 100% of all core services using the NACHO core services. And then we let the model run to give us the estimated staffing and spending. And once we do that, and Matt, you just jump in whenever you're back online. Once we do that, we look down, we kind of add it up for everybody. And here we're using our population weighted numbers as the best. So we came up with a state total of about 6159 for staffing. And you can see right next to it, we actually kept track of the actual staffing, which was around 38. So if we wanted to bring every health district up to the full, doing the full complement of natural core services, then basically you'd be increasing your staffing by 62% right there. Now, natural core services is not a perfect proxy for what would be needed for accreditation, but it was realistically the best one we had at this point in time. So that's what we did there. Do you want to jump in, Matt, or do you want me to?
Sure.
Okay, there you go.
Advance to the next slide showing the expenditures gap analysis.
Okay, you can take it away.
Oh, thanks. Depending on whether you use the unweighted or the weighted estimate, there's a gap of between 26 and 44% between actual spending on core services and what would be predicted of all health departments provided all core services. And the dollar figures are quite impressive. A $100 million gap between 2011 expenditures and that maximal level of expenditure for 100% of all services in all health departments. So this is the last slide, I believe. So how do we make sense of these figures from the gap analysis? Well, we look for any kind of a benchmark from other states and learned that a gap analysis had been done in Minnesota in 2007. There, Riley and others estimated that the gap between actual expenditures for core services by local health departments in Minnesota, they refer to them as areas of responsibility, and spending needs that were determined by a consensus of expert opinion of local and state health officials, put the gap at about 11%. 2007. Now, given that this gap analysis was done before the recession and during which the local public health system lost significant amounts of revenue and staffing, and given that the Ohio local public health system depends so heavily on recession-sensitive revenue sources like local property and income taxes, this 26% state gap in expenditures from the unweighted estimate doesn't seem that implausible. So that's, I think that's all we have to present, Patrick, unless you want to add anything to this gap analysis. And I believe we have time for questions.
Yeah, nothing to add. Yeah, the great thing about that gap analysis is, like I said, it kind of gives you a price tag in terms of money and staff for what it might take if you wanted to bring everybody up to accreditation standards.
Fantastic. Thank you, Patrick and Matt. This is really great work, obviously, and is really informing a lot of work that's happening in the field and a lot of thinking that's happening in the field now about how we can do more of this kind of analysis from a cost estimation standpoint, given how important these issues are to answer across the country. So questions that folks have for Patrick or Matt on this analysis. Feel free to type in questions in the chat box if you're on the web on the website portion of this webinar, and if you're not, you'll just need to vocalize, and we can give you the floor.
First, I see Dr. Livingood's question about the range of population. And we use the actual ranges from Ohio, and I just did some conversions. And that goes from some small ones, 6,500, up to some of the larger health districts, which were about 850,000.
How many, this is Bill Livingood, how many of the smaller health departments were there below 100,000? I'm just wondering, because I understood that from some of the
I can tell you, yeah. I can tell you in 1 second. There were 96, and hang on, that was 96 out of 124, so about 2/3 were below 100,000.
Okay, great, thank you.
And we got a question by Renee. Can you see that, Patrick?
Yeah, I'll let Matt take this one.
So the question is, what is the plan to share information, these results with local policymakers and public health directors in Ohio?
I see that question from Renee, and I can try to respond. This model was with support from the PBRN National Coordinating Center, was in essence commissioned by our State Association of County and City Health Officials, AOHC, as a follow-on to a public health futures project that our SHO initiated to identify the core minimum package of services that all health departments should be providing in Ohio, and that was urged upon our SHO by the governor's office and the legislature. In fact, the legislative study committee was convened and recommended that our SHO proceed with costing out this minimum core package of public health services. And by completing this cost estimation model, we've enabled our SHO to respond to that legislative mandate. We've made it available to the association leadership and membership, and the model is now available to members for estimating the gap between their expenditures and what they believe they should be providing as far as the range of core public health services within each member's health district.
Fantastic.
Yes, I see I'll take the next question. Maybe we'll be able to alternate. I see Rex's question about the data. It reflects accounting costs. These are actual expenditures. They're not budgets, they're expenditures. I prefer expenditures when I can get them because that was money that was actually spent. So it's a little bit more real than a budgeted number. The core service list is inclusive, open-ended. Okay, for Barry's question, that was simple. For the NACHO services, what we did is we had classified the NACHO services according to core and non-core, and then those other categories, as you saw, service categories. But we just counted within each one percentage completed. It's not the best measure, as we note, because some services are much more resource intense than others, but it's what we're using what we can. As a matter of fact, the studies that we're doing now, the studies we're initiating now, will start looking in greater detail at the actual resources going into some of those services.
Great. Other questions?
Oh, I just saw Rex's follow-up question. The opportunity costs, the resources that are owned by the local health districts, that gets into a broader question. I think that's where we're all heading. In other words, I think please correct me if I'm wrong, if you're asking, because the opportunity cost of a nurse doing nutrition is what would how much more useful or less useful would that nurse be in terms of QALYs, let's say, quality adjusted life years generated, if that same nurse was used instead in immunizations or some other area. And I think that's where a lot of our research is headed, but I don't think we have the precision to do that yet.
This is Bill Livingood. Just a kind of, I guess, point of discussion that might be worth looking at related to this research is Rex Santeria, I guess, has done some work showing, some economies of scale particularly with the health departments under 100,000, as I recall. But and you know, for instance, in Georgia, we have county health departments with populations as small as about 2,000 people or under 2,000 people. The ability of you know, a community with that few people to be able to do core functions or anything else, there would appear to not be an economy of scale there that would allow that. So I guess I'm kind of raising the issue. It seems kind of, your findings seem to be a little bit counterintuitive, even though you seem to have populations that were pretty small. And I was just wondering, what, you know, is that, do you think that's because that's the reality of how services are delivered in Ohio, or do you think it might be that there might be some kind of design flaw that didn't pick up the sensitivity to economies of scale? And you know, I'm just kind of throwing it out there as a discussion point.
Yeah,
Before
as
any
far as
response, this is Scott Frank. I wanted to just share a little bit in more detail about health department size in Ohio. I have it in front of me right now, and looking at health departments below the size of 50,000, 57% of our health departments are below 50,000 population served. 21% are between 10,000 and 24,000 in size, and we have 4% of our health departments that are less than 10,000 in size. Our smallest jurisdiction is about 6,600 in size. So we are dominated to an extent by small health departments, and that may be changing, and the Consolidation project may comment on that as well. But that's the best information about jurisdictional size of the 50,000 or below health departments.
And I think in some of our reports, Bill, we acknowledge one possibility. Again, we're dealing with the data that we have, so we can't second guess it. But if smaller health districts were more likely to say that one of their NACHO services was fulfilled, even if it was only partially fulfilled, it would still count as a yes. So they get the count, they get the count for the service. So even if their costs were higher, that might offset it. But again, there's no way to, that's just a guess, and there's no way to tell that.
Mm-hmm. As a health
and I have no reason to suspect it.
As a health director of a small health department, I would say that we would be checking off a service as fulfilled if that was one we were doing jointly with another health department, and I would think that most small health departments would handle that in that way, and that may influence results to a degree.
Great point. And that logarithmic functional form, semi-log functional form you used might also be capturing some of that as well, at least in your non per capita models, right? You're putting population on the log scale, but dollars on the natural unit scale. That would
I've run the models the other way, just for my own amusement, and you see curves.
Right. Great discussion. We do have another question, a quick question from Susan, and then we still have another presentation to come from Ohio, right?
Yes, we do.
Okay, yeah, so I want to make sure we preserve time for that. But Susan's question, just asking for some general advice about researchers who may want to undertake this kind of analysis in other states, other PBRNs. Any thoughts that words of wisdom you might have quickly for those states, Patrick or Matt?
Sure. Yeah, Susan. I think I've even said, again, I'll be putting something out on this study shortly, but just call me. It's, I can kind of help you with some of the technical stuff. The two tricks that I mentioned, it really helps a lot if you split the services both between core and non-core
because our models for core were very accurate. For the clinical, they were not so accurate. So it really helped to split the services, and also that population matching, the county subdivision turned out to be extremely helpful.
The only thing I would add, this is Matt, the only thing I would add to Patrick's comment is that I would encourage researchers from other states to look at using or adapting this model, because there are health departments in all states that are interested in determining how their current expenditures align with a defined core minimum package of public health services.
Absolutely. This is a topic of considerable policy and practice interest. Thank you, Matt, and thank you, Patrick, for stepping us through your research and progress on that piece. And we do now want to turn the tables back over to Matt and a slightly different set of colleagues and collaborators to talk about a second quick strike study looking at consolidation of local health departments in Ohio.
Thanks, Glenn. This is Matt. I'm going to lead us off and then turn it over to my colleagues, Mike Morris and John Hornbeek. I'm going to present some results from our other quick strike through RAFI in Ohio concerning consolidations of local health departments in Ohio and the motivations and impact of consolidation. First, our disclosures. We have no conflicts of interest to report. We acknowledge funding from the Robert Wood Johnson Foundation, PBRN Networks project based at the University of Kentucky, and in Ohio, RAFI at Case Western Reserve University. We have an extensive list of collaborators in Ohio from the practice and research community at Case, at Kent State, and through our Association of Ohio Health Commissioners, as well as at the University of Arkansas. I also want to acknowledge, especially personally, Joe Mazzola from the Ohio Department of Health, who's helped in gaining access for us to the administrative data sources that we used for the analysis was invaluable, and for his persistent efforts in continuing to improve those administrative data sources known as AFR. So why would we look at motivations for an impact of local health department consolidation? Well, as a local health officer for almost 25 years in a county that had 4 health departments when I started in the job in 1988, these questions about the value of consolidating came up all the time. My experience is not unique, although Ohio has 88 counties and has 125 local health departments currently, with a number of other counties besides my own having multiple health departments. So health commissioners across the state were facing and do face these same questions about the costs and benefits of consolidation all the time. As you see in this slide, at the center of the chart, the slide, there's a chart showing how consolidations have been taking place in Ohio all along. In fact, a dozen alone in the last 10 years. So this is a current phenomenon. So last year, when I was approached by city officials from Youngstown, the health department, the city in Mahoning County, where I served as health officer, that maintained its own health department, I looked for any evidence available to answer some of these questions about the costs and benefits of consolidation, such as, would merging health departments result in lower costs? Does a combined health department generate more revenue, and does this increased revenue cover the additional costs of providing services to a consolidating city? And are counties with one combined health department able to attract more state and federal funding? Fortunately, I had become acquainted with researchers in the PHSSR community who were interested in such questions and were able to work with the data available to us to provide some answers. The quick strike study results we're presenting here today with my colleagues, Dr. John Hornbeek from Kent State and Dr. Mike Morris from the University of Arkansas, are our attempt to answer some of these frequently asked questions about consolidation of local health departments. Our research objective is to develop evidence regarding the effect of consolidation on expenditures, revenues, and services of local health departments in Ohio, and to deliver actionable and timely findings to inform consolidation policy decisions that are being taken at the local level in Ohio and being discussed at the state level. I'm going to turn things over to Dr. Hornbeek now, and I apologize for not being able to remain on the call because of another commitment. But my contact information is included at the end of the presentation. John?
Thank you, Matt. Appreciate the introduction to the project and obviously the expertise you've brought to our collective efforts here. Lizeth, should I go ahead and move to the next slide? I apparently have that ability because I just did if people are seeing it.
Yes, it's up to you.
Okay, great. The following slide here outlines the 4 things that we'd like to do today with the time that remains. We'll overview briefly the aims of the study and its structure, summarize the research methods that have been used here, present some findings for both the large N and the small n interview-based portions of the study, and then we'll summarize briefly the findings and implications and share at least our next steps on what we think might be productive to do in follow-up to the work that has been done here. I think what I'd like to do now is turn the floor over to Mike Morris, who will cover the first 2 of the bullets on that slide, the overview of the study aims and the structure of the project, and then the summarization of the research methods, both from the large N and the small n perspective. I'll then step back in and present findings and summarize those findings at the end with Mike stepping in where he sees fit. So I don't, Mike, are you with us and want to take it from here?
Yes, John, I'm here.
Okay. Do you want me to, oh, you got it.
Okay. Our first thing that we want to be doing is looking at assessing the pre and post consolidation differences in the overall and expenditures and administrative expenditures of these local health departments that were engaged in consolidation activities. Also, we wanted to explore whether or not revenues from non-local sources were actually changing. This would be reflecting grants and other funding from different sources that people in Ohio were wondering is having larger consolidated health departments, does that make it easier for these organizations to compete for monies from outside of their local jurisdictions? So that were the 3 main focuses that we'll be talking about today. And we approach this both from administrative data and quantitative analysis, and then also through a qualitative interview process. And here we see the structure of our project. We've called these 2 different parallel research efforts the large N component, which is the analysis of the annual financial reports, AFR or AFR data that you've already heard about through the presentation that Patrick and Matt gave just a few minutes ago. This is really good annually collected data, and it serves as the backbone of this project from the large N perspective. And then we've brought in a number of other data sources that we'll talk about in depth in just a minute, but we're trying to control for community level and population level factors that may influence expenditures and revenues. The small N part of the study was led by John and the team from Kent State. And what they did was they went out and talked to people that were involved in these consolidations, the health department leaders, in some cases the mayors of the communities were involved, to assess, first off, why did they want to go about consolidation, and secondly, what did they see as a result of these consolidations? The large N analyses, as I said previously, The AFR data served as our backdrop or the backbone of this study, and it's an annual report of financial and other administrative operational data from health departments throughout the state of Ohio and are done annually. We ran into a little problem because prior to 2008, the data was not available in any type of electronic format. It was just in paper copies. Our colleagues over at Case Western, Scott Frank and his group were kind enough to give us part of that data that they had entered as part of another project, which got us down to 2005. And then research assistants here at the University of Arkansas entered the remainder from 2000 through 2004 from the original paper copies. We've got community level data from the U.S. Census. We match by FIPS codes and very similar algorithms that Patrick was describing earlier. And then we also wanted to bring in other community governmental factors such as the city budget data, which we obtained from the auditor's office there in Ohio. And then we also got governmental structure data about the mayor systems in these communities that was done by the Ohio Municipal League in conjunction with Kent State in a previous project. Our analytical approach, we have an issue here. Our differences that we have in these outcomes, the expenditures, the revenues, are they different because of the consolidation, or were these organizations that consolidated, were they just different to begin with than those health departments that chose not to consolidate? So we have potential for a selection bias issue, and so we thought that we needed to approach this on a from a two-stage modeling approach. We selected a Heckman model, which is widely used in the literature to address selection biased issues, and we'll talk about limitations a little later. But we chose to use a two-stage Heckman model to address the potential selection bias and who consolidates. And then another thing that we had to do was, well, how do you operationalize these concepts? What is a consolidation? Consolidations take on a number of different forms, and what we decided was our focus were voluntary consolidations, conscious decisions made by cities and counties to join their enterprise. Ohio has a statutory regulation in place that if a city drops below 5,000 in population, they no longer are legally allowed to operate a independent health department. But we didn't think that those were the same type of animal as consolidations made between a city and a county that decided and went through the actual decision process that, yeah, we're legally allowed to run a health department, but we think it'd be better if we joined together with our county to make one larger organization. So we did not count consolidations that occurred as a result of Ohio law that would not allow these cities to continue once they dropped below a certain population. Our next issue that we had to do was to define, well, when does a consolidation occur? When do we count the pre and the post? What do we use to demarcate between those two time periods? The year of consolidation was what we finally decided on to use as our pre-post. Ideally, we'd like to have been able to drop that year of consolidation, but because we're dealing with such small numbers and the times involved, we decided that it was better to try and keep data. So the actual year of consolidation is what we used as our dividing line between the pre and post periods. then how do we look at changes in expenditures and revenues? There are a number of different ways that are presented in the literature, and we tried a couple of different approaches to this. Finally, we came down with the feeling that the best way to approach it was to add the city and the counties that consolidated in their pre-consolidation period, sum those up, and then compare those to the post-consolidated period for the overall consolidated county health department. Our analytical model for the large N utilizes a two-stage approach as we mentioned earlier. And in the first stage, we, based on discussions that we had had with people that had been involved with consolidations in Ohio, and also through the findings from our qualitative interviews or the small N study, we came to recognize that really the cities were, in many cases, the driving force behind these decisions to consolidate. And so we took a city-centric view of the first stage model for predicting consolidations. So some of the things that we included in our model were the mayoral system. Did they have a strong mayor or a weak mayor system? By a strong mayor system, it's talking about an elected official who has regulatory abilities and authorities within the system of government there in the city, and is able to act independently as an elected official. A weak mayor system, the mayor is splitting with an appointed city manager, the actual operational controls of the city. Dr. Hornbeek is the political scientist, so he could elaborate that much better than I can in terms of the differences there. We also considered the population level of the community and deficit spending by the city. We used that because we were thinking that cities that had more financial pressure on them may be looking for options of how to divest themselves of some services that they were expending resources on that they might be able to contract with the county to do at a cheaper rate. Similarly, we thought that perhaps local health departments that were losing more money in their operations might be more inclined to look for a consolidation partner. So we used those four components in our first stage to predict consolidation decisions. Then we took the consolidation decisions and looked at whether or not consolidating a health department, a city health department, with a county health department, and that is necessary to point out in all of the cases in Ohio that we're dealing with, it's city health departments consolidating with their county health departments. These health departments do their consolidations. Does that affect the total expenditures per capita, their administrative cost per capita, and the percent non-local revenue in terms of their overall revenues? We controlled for jurisdictional characteristics such as the metropolitan, micropolitan area. And then also the overall city government spending to try and control for the proclivity of the local government to spend money on civic functions. We control for demographic need-related population characteristics such as the overall population, the population density, the percent poverty, and the percent minority in the population. Then for the small N study, the second part of our project, we utilized a phone interviews with mayors and local health department officials that were, in most cases, actually the ones involved with the consolidations themselves, or in a couple of instances with the person that followed after them in office. But what we were able to do was to get pretty in-depth discussions of what went on in the decision process, as well as what the people that were actually engaged in the consolidations felt about their success and the ramifications of their consolidation on services and capacities, expenditures and revenues for these health departments that consolidated. These were run between January and April of last year. Okay, and now I'll turn it back over to John to give you some of the results from what we found through this process.
Great. Thank you very much, Mike. And Mike, please chirp in as we proceed here if you think that a point I may offer needs amplification. What you have in front of you now is a slide from the interview results. We spoke with 17 senior health department officials out of the 20 departments that had consolidated between 2001 and 2012 in the state of Ohio. And a very large proportion essentially said that the reason they consolidated was to save money. Perhaps surprisingly large portion of them said we're also about improving services. About almost two-thirds of those we interviewed indicated that was the case, and then there were a handful that pointed to building long-term capacities and increasing efficiencies as well. Another characteristic from the interview data that we collected was that by and large, those with whom we spoke were reasonably positive about the what happened after the consolidation, and they asserted in most cases that the goals that had been put forward originally had to at least some degree been achieved. 13 of the 14 who indicated that saving money was a goal said that they in fact did save some money. All 11 of those who said that they were in it to improve services said that in fact they did improve services, at least that was their viewpoint. In addition, 5 of the 6 who said building capacities was a key goal indicated that goal had been achieved in some fashion. Overall then, talking to the people who are running these newly consolidated departments now, they viewed the consolidation as a good idea in retrospect. 15 of the 17 involved pointed to that reality. One of those 2 who did not left an I don't know response. So really, from the interview information, there was a positive view from those who are running the consolidated departments now. Next slide focuses in on the who consolidated. And the best way to think about this is the first stage of the two-stage Heckman model that Mike Morris pointed toward just a moment ago. There were several variables evaluated in that model, and controlling for population, 2 factors seemed to emerge as increasing the odds that a department would consolidate. One factor was if the city government in which a city health department resided was running a deficit, they were almost 10 times more likely to consolidate than those where that did not occur. And then likewise, cities where there was a strong mayor governance system, the net effect of which is likely to be a situation where the mayor has direct and electorally accountable responsibility for the revenue and expenditure side of a city government, and those individuals were present, and when they were present, increased the odds of a consolidation by almost 3 times. And I think if you think about this makes sense in weaker mayor systems where there are more diffuse responsibility for for the operations of government, which may occur when you have a council-dominant local government structure, you may find more particularistic interests, greater responsibility to more particularistic interests in that process. Interestingly, the financial condition of the health departments themselves was not a particularly strong indicator of consolidation in comparison to the two factors that identified above as emerged from the logistic regression analysis that Mike and his colleagues worked on for us. What about the consolidation's impacts on expenditures? The results there indicated a decrease in expenditures becoming likely after consolidation. In a sense, this confirms what we were told by the health department directors in our interviews. They were perceiving they were saving money because the AFR data that documented it essentially indicated that they were saving money in statistically significant fashion. The administrative expenditures portions of the model were not statistically significant. I think, and Mike can comment here as he chooses, our sense is that may be a function of sample size, but we couldn't reach a strong conclusion on the administrative expenditures. Those conclusions were generally supported by the portions of our interviews that focused in on the impact of consolidation on expenditures. Just over half of the officials we spoke to reported that total public health expenditures were actually reduced. Just under half said that they were not reduced. However, of those that were reporting reduced expenditures, virtually all attributed those reductions to the consolidation. I think likewise, we looked, the difference between the first set of statistics in the bullet under the small analysis is that it focuses on total public health system expenditures. That would include external revenues and grants. So we asked also about public health expenditures that are financed by local revenues. And here it's where the cost savings became more evident in our interview data collection processes. Almost all cases for cities and all of the counties indicated that public health expenditures from local revenues did not increase after consolidation, and almost 3/4 of the cities involved indicated that they reduced public health tax burdens for that particular city. So the nutshell here is from both research approaches, we are seeing reductions in total expenditures, and it appears based on the interview data and the data that we're seeing that those savings or those reduced expenditures tend to be benefiting the cities, and in a sense it's often it has been the case that sometimes when there is financial problems in those cities, they seek to save money through this process, and there appears to be some evidence that that's in fact what's occurring here based on the results that Mike was able to generate for the large N analysis and the interview results. That was all as expected. I think one of the other arguments that is sometimes made around consolidation of health districts is that will increase external revenues somehow. And I think it's fair to say that both our large N and small N interviews found that at least over the short term, within the first year or two after consolidation, we had trouble finding revenue increases. In fact, the large N analysis showed a statistically significant decrease in non-local revenues after consolidation, and the small N analysis found that the majority of those we spoke with indicated that revenue did not increase within the first year after consolidation. Now, I think there's a nuance in the first bullet under the large N analysis in the screen you're looking at, and that has to do with timing. Mike was able to run a series of different modeling approaches that differentiated all of the years post-consolidation from just the first 2 years of post-consolidation. In other words, trying to evaluate the impact of the consolidation within the first 2 years versus all years after versus only those that would be 3 years and beyond. And what those analyses suggested is that if you take all the years, there's a statistically significant decrease in local revenue. If you take just the first 2 years after consolidation, that statistically significant result is maintained and strengthened, suggesting that a fair amount of the impact occurs in those 2 years. If one runs a similar regression analysis for 3 years and beyond, the effect disappears. And that kind of statistical result is consistent with what we hypothesize may be a transition effect that did in fact appear in the interview data that was generated through our discussions, both as a part of this project and with other departments that had been involved in consolidation efforts. So what I'm going to share with you in these summarized regression results is the fact that the post-consolidation variable is statistically significant and has a coefficient of 0.417 when you take all years post-consolidation, controlling for the other variables listed in the table and the one noted on the asterisk below. And then if you look at the next table, this is only looking at the first 2 years, and you see the coefficient strengthens, becomes 0.477, controlling for those same sets of variables. And if you run a regression equation that looks at only the years after year 2, the statistical significance disappears. We don't know exactly what happens, but the strength of the relationship is not there after 3 years, and for that reason we're hypothesizing something like a transition effect. I should say, however, that suggests that there may be some more research that's appropriate in this case, because people have argued that in fact when you combine departments you strengthen the ability to get external revenues brought in, and there were anecdotal examples of cases where that occurred, but the larger set of interview results and the larger statistical analyses suggest that there's more likely to be a negative effect initially because people are adjusting to a new situation and working on things perhaps other than retrieving external revenue. We also asked about perceived impacts on services, and I'll run through these numbers very quickly. About 70% either of those we interviewed strongly agreed that services improved within 1 year of the consolidations taking effect, and those numbers increased as you asked about larger amounts of time afterwards. About 80% said that services were at least maintained in the year following implementation. We have heard people tell us, however, that they had to work pretty hard to maintain the same services as the department was actually going through a transition stage. But as you see, if you look after 2 years and 5 years, that challenge of maintenance is reduced as the department kind of returns to a new state of normalcy, if you will. We also asked about whether there were any service losses associated with the consolidation. The health department administrators we spoke with, almost half of them, said there was some kind of loss, although the vast majority of those, 7 out of 8, if I recall my numbers correctly, said that the loss that was endured was not particularly significant. Generally, they were services that were involving providing targeted assistance to to a nursing home or to a prison in one case, and they felt that by losing those services and reallocating revenues, they were likely to have increases in overall program effectiveness moving forward. And so there were, I think, generally positive views on the part of the departments that we spoke with about the impacts on services. We saw some positive views regarding capacity development, and I think perhaps more work needs to be done in this area. About just over 50% said their capacity had increased. Couple said their capacity had decreased, and their resources were spread thinner in those cases. Many said their capacity stayed about the same. By and large, this was the case where very small city health departments were merged into much larger county health departments. Layoffs were not particularly common according to our interviews. Over 3/4 said that affirmatively there were no layoffs. Only 3 of the 17 indicated that there were layoffs of some kind, although some did mention that attrition does occur or did occur during the process for the health departments involved. Of course, attrition would occur across the board, but in this kind of situation might be exacerbated. One of we had done some work last year prior to this study looking at the consolidation that occurred in Summit County, and one of the things that emerged in that particular consolidation was the view that by consolidating you can look at the world in a whole new way, and that opens up new opportunities for public health improvements over time, new strategies and approaches, in addition to not having health departments in effect competing with one another for partners or grant dollars and so forth. And we did find that the majority of folks that we spoke with from amongst the health districts did believe that that new opportunities did materialize, and the proportion believing that was the case increased over time. So again, you've got this period of transition and turbulence after which a new equilibrium may set in these organizations, thus allowing new opportunities to be seized. At least that was the perception that was shared with us in some of the interview results. So if I was to summarize briefly kind of what I've shared with you, and I'll mention we've tried to pull the key findings from a 50,000-foot perspective. Mike or Matt or Josh or I will probably be happy to chat with anybody individually about various pieces of this, but these are kind of the big things that emerged. Community level factors are relatively strong predictors of consolidation. The financial condition of the city and the strength of the mayor's governing role appear to be significant here. Total expenditures do tend to decrease after consolidation. This is as advocates of consolidation would suggest. And this means for health departments that consolidate, particularly city health departments, they can reasonably expect to save some money in most cases. The administrative cost question probably does need some follow-up work, perhaps with a larger sample to discern effects there. I think our research leaves an open question there in a sense. And then we did find that non-local revenues decreased post-consolidation, at least in the short run. When Mike ran a series of altered specifications for the model, he did find that that effect disappeared after a few years. The implication there is that people that are involved from a management perspective in consolidating health departments need to be thinking about this managing these short-term transition effects, because they can have real impacts moving forward. I think the participants in these consolidations, at least the ones who we spoke with and who operate those county consolidated health departments now, were pretty positive about goal achievement. They saw new opportunities flowing from the consolidation, and the vast majority thought the consolidation was a good idea. However, there is more research and work to do here. I think we feel like we've made some progress with this work, and I think Mike's work at Arkansas and Matt's insights in terms of his experience were very helpful to the whole effort to try to get us moving forward. But we do have some more work to do potentially in workforce impacts, looking at more objective data on services, capacities, and opportunities to the extent possible. I think we have recognized the limits of our sample sizes, both in terms of the large N and the small N work, and I think there is some enhancement in terms of methodological approaches that could be undertaken here, and so those are things that might pay some attention to going forward. We also recognize that we have focused on one universe of consolidations here, city-county consolidations in Ohio. There may be sense in looking at other states with this kind of mixed method approach. There may also be sense in looking at other kinds of consolidations that may involve different kinds of entities. So these are pretty much the results we would share with you all at this point. We plan to continue disseminating the results of this work. We've got got a policy brief that was completed in June. We'll be updating that over time. We have a final report that lays out details on methods and more complete overview of the study. That's for those that have more time to read. We will be doing a presentation at APHA on this work, and Mike and Matt and I and Josh are piecing together that presentation now, and we do hope to refine and seek publication of this work in peer-reviewed outlets, Frontiers, and or perhaps others. I think there is, as I mentioned before, some more research that can be done, but we hope we're taking some positive steps here to sort through some of the questions and issues involved. So that's pretty much all we have to share with you all at the moment. Thanks for your time and attention.
Fantastic. Thank you so much to John and to Mike and to Matt, who I know has had to leave us early. I know we've got a lot of questions on this one as well, because you guys are investigating some really high priority topics that are at the policy and practice forefront here. We are running short on time, and so maybe we could just take a couple of quick questions. We've got, I know, 2 or 3 that have been typed in. First one from Barry asking about, wondering about whether the spending reduction you saw post-consolidation might have happened anyway due to just a general temporal trend of declining spending over this time period in general. A quick thought on that from either Mike or John?
Barry, thanks so much for that question, because that's a very good one. And yes, I would like to incorporate a control for trend into models going forward, because that potentially is an issue. It doesn't, just based on what we are looking at, I don't think it is a problem, but I definitely would like to actually incorporate that specifically in the model. And Rex, you hit my issue on the head. I tried modeling this originally with a control function approach, like a residual inclusion, and I was having trouble with instrumental variables. This was a quick strike, and the time frame that we had doing this, I only was able to try a couple of different things. I never could get a good instrument, and so I went back to just using a Heckman. I would love to try some more, look for some more instruments, see if we can find something good that actually will work, or go to like the GLAM, generalized latent class model type things, because as you're right, this is a switching with endogeneity potentially, or at least I should say potentially, an issue of that.
Right. And I know we've got some other questions, but I think we've got to call it. We've got to call it a day so we can have a little bit of time for our few other items on the agenda. So for CB's question and Scott, Frank, and Renee, we'll see if we can get answers to those questions offline from our speakers today, and we'll interesting work. Thank you again, Mike and John, and thanks to Matt as well. So because of the great work happening in Ohio, we've obviously expanded our research in progress segment this month. We do have a few other items we want to make sure to at least highlight in our last 10 minutes or so, more on the administrative side of our agenda for today. And so quickly, some updates just from research relevant activities and that have played out over the last month or so to make sure you're aware of. First of all, the Institute of Medicine released their report on the Clinical and Translational Science Award Program, the NIH program that was under review by an Iowa committee. If you haven't seen that report, it was released last month. There are some very important nuggets relevant for PBRNs, and we know that a number of our PBRNs are affiliated in some way with a CTSA institution at a university. And so we encourage, especially those of you who are engaged or want to engage with your CTSA, to take a look at that report. Among the recommendations are a recommendation to continue and enhance the focus on community engagement in the work of the CTSAs, and which obviously plays into a lot of the work happening in public health PBRNs. And also a pretty strong recommendation for CTSAs to continue to build on partnerships with other research networks. And again, PBRNs represent one very important class of other research networks that academic health sciences centers can and should be collaborating with. So take a look at that report. It's on the IOM website, iom.edu, and you can find it pretty quickly. Another important report that came out last month is the report on public health quality measures. Make recommendations for approaches for measuring quality in public health, specifically measures that are linked up with the leading health indicators, the HHS leading health indicators. Some really important recommendations out of this report as well that are particularly relevant for our variety of PBRN studies that are looking at developing and analyzing measures of public health delivery, like the kind of measures we're using with the IMPROVE study. So we encourage all of you to take a look at that report as well, the framework that's introduced there, as well as recommendations on measurement strategies with a focus on the leading health indicators. Again, it's available on the IOM website, iom.edu, and you can find it. And we'll certainly have further discussions about some of those recommendations and ways that we can make progress on them through the public health PBRN program. We've got a quarterly training webinar opportunity coming up through our PBRN program next month. We're going to be featuring the TRAIN system that is developed and maintained by our colleagues at the Public Health Foundation with support from HRSA and CDC. TRAIN is the online workforce development and tracking system that has been developed and up and running for a number of years now. Provides some important, potentially very valuable data for studying exposure to workforce training in public health, for studying take-up and studying the variety of issues around workforce training activities and ultimately how they influence public health practice. And so we're going to feature a webinar next month introducing you to this emerging and growing data set and giving some examples of how it can be used in public health services and systems research. So I want to make sure you have that on your calendar. Another important initiative that was released earlier this month from our colleagues at the Agency for Healthcare Research and Quality, a report and a new atlas of measures on clinical community relationship measures, CCRM, have been released, a series of reports from that project. This was an initiative started back in 2011 to develop measures of how well clinical settings are engaging with community settings, and what kinds of relationships clinical settings, especially primary care settings, are forming with community settings, specifically to support the delivery of clinical preventive services, health services. And so these measures and the report out of this atlas that was released most recently obviously had a lot of potential relevance for the kind of work, research that we're doing for the PBRN program, especially research looking at this, again, this interface between public health and primary care, and what some of the new models of delivery that are coming out of the Affordable Care Act opportunities and other initiatives as PBRNs continue to think about how we can study these innovations and the effect of these kind of, public health and healthcare relationships. These kind of measures are really, potentially going to be very valuable to us. So we'll probably be talking more about this set of measures as well in future webinars and meetings. But again, we encourage you to take a look at this report. It's available on the AHRQ website, ahrq.gov. If you just go to the website and type in CCRM, you'll see the report. It's also featured in one of the AHRQ's Healthcare Innovations Exchange profiles that are up on the AHRQ website. Dissemination opportunities. I'm going to turn it over to my partner in crime, Anna Hoover, our Deputy Director, to talk about some of these dissemination opportunities very quickly.
Hello, everyone, and I'm going to turn into the FedEx guy from the 80s here, or do my best to. Frontiers and PHSSR, learn it, live it, love it. We know some of you have some data coming in. Some of you have some analysis that you've done. Please consider submitting some of those early findings to Frontiers. This is not just your standard sort of journal to submit to put on your CV. This is also a way of reaching practice audiences because, as you know, it is not behind paywall. And a lot of health department personnel just do not have the budget to access many of our top tier journals. So we want to make sure that they're getting the findings they need to make the decisions that they need to make. So please, by all means, do consider submitting to Frontiers early and often, as Glenn likes to say sometimes. I'd also like to say that we are revising slightly the way we do the Keeneland Conference. We thank you, those of you who responded to the evaluation. One of the things we are going to be doing is constituting an external steering committee. Some of you may be contacted about that to help guide theme development, to help with some of the review, and make sure that the conference is the best that it can possibly be. So we're very much looking forward to working with you all on that and doing another evaluation in a few months and seeing how we've done. So those calls for abstracts should be coming out. We're hoping to get them out the week before APHA. So get that on your radar. Be thinking about what you might want to submit. And we should have those out about the third week of October or so, that call for abstracts for Keeneland Conference. And we'll be talking with you soon about ideas for the agenda for the PBRN grantee meeting. In other items, I know that I mentioned last month that we're in the process of a website redesign for both the PBRN and PHSSR Center's shared website. As part of that, we would like to have a standalone page highlighting each PBRN, so each PBRN will have its own page that describes its function, its personnel, its funded research that it has conducted, and also provides a space to park some products that you might want to disseminate to wider audiences and share. We also hope to have a page for each research project that has been conducted from our research portfolio that also links out to projects and then links back to the PBRN. So we're looking at some serious cross-functionality in there. We'll probably be in touch with you very soon, specifically to ask things like pictures, because a picture on your standalone PBRN page is going to make it much nicer to look at than just all that text. So please, by all means, be thinking about how your page could be developed in a way that would help you. Obviously, we want some standardization in appearance, but we want to make sure that we're also getting your materials that need wider dissemination out there. Finally, APHA is around the corner. We're going to be asking you to please let us know if you have presentations, if you can send us the title, date, time, if you know the location, any of that material. Obviously, we'll be putting together another list for the meeting that we'll disseminate in advance, and also at the meeting that lists all of our PBRN related presentations so that everyone knows where to go to see your friends and colleagues working in similar areas. I think that gets me through the dissemination section. I'm going to kick it back to Glenn for the last 2 minutes and the funding opportunities.
Funding. Everybody's always interested in funding. Again, we have a current call out for quick strike research applications through our PBRN program. If you've got an idea for a quick strike study, time sensitive, high priority, high policy, high practice relevance, high potential to lead to further research down the road, we want your application. We're going to review the first batch of applications that come in during this month, August. And so if you want to get first consideration, get us your application in this month. You just heard what great things can be done with Quick Strike Research Funds. The two projects you heard from Ohio today, both funded by two Quick Strike Research Funds from last round. We also have a few more days open for the RWJ, Robert Johnson Foundation's Mentored Research Scientist Award in Public Health Services and Systems Research. And so again, if you have colleagues, know of others who are eligible for that award, just a reminder, the deadline is coming up later this month for submitting to those applications. Information is available from the RWJ website and also from our publichealthsystems.org website about that opportunity. Finally, I'm sorry?
April 21st deadline, so you've got 6 days.
August 21st. You've got 6 days.
August, sorry, every time I think an A, I think April. August 21st, so you've got 6 days. And if you've got to route internal approval forms like we do, you might want to get that moving.
Yeah, get it in gear. That's a great opportunity. Lastly, we wanted to highlight two awards that are out from CDC now on the street. One is the funding opportunity for new and renewed funding for CDC's Prevention Research Centers program. We know that several of our PBRNs work in tandem and collaborate with university-based prevention research centers. Know that all those centers are up for renewal now, and other universities can apply to be newly funded PRCs. There's new language in that FOA that encourages more practice-based research, more public health practice relevant research. Now is a great time to reacquaint yourself with your PRC and colleagues who really may need to collaborate with you and your PBRN to remain as funded prevention research centers. So I want to make sure you all know that application on the street has got a mid-September deadline, so PRCs are furiously working on these applications now. If they haven't already reached out to you, you may want to be proactive and check in with your colleagues, see what role your PBRN might be able to play in renewed funding for the PRCs. Similarly, CDC has a funding opportunity announcement out for the refunding of their CDC-funded injury control research centers, the ICRCs. We've talked about the lots of potential for PHSSR in injury prevention and control and PBRN opportunities for engagement in that research. So again, if you've got injury prevention and injury control colleagues, if you're affiliated university within your health departments, now is a great time to see what role your PBRN might play in putting forward a competitive application for a CDC-funded injury control research center. The deadline on that, I think, is a little bit later. I think it's in November, mid-November for that. We are out of time, and so to respect your time, I want to go ahead and close us out for today. If there's questions that you have that haven't been answered, please feel free to send us an email. Next month, we've got scheduled to hear from New Jersey, our New Jersey PBRN, on some of their research in progress, so you won't want to miss that. Otherwise, give us a call, send us an email to Public Health PBRN, and we will look forward to continue to engage with you as we move forward. Thanks to everybody. Thanks to our colleagues in Ohio for the great work you're doing. Let us know how we can help. Keep your cards and letters coming, as they say. And thanks so much, everybody, for joining us today. So long.
All right. Thank you.
Thank you.
Thank you.